Good evening and welcome, everyone. I'm Laura Erskine. I am the director of the UCLA Center for Healthcare Management and faculty in the Fielding School of Public Health. On behalf of the Center for Healthcare Management and the Fielding School of Public Health, thank you for joining us. This session will be recorded and we will make it available on our YouTube channel. But before we begin, I want to make sure that we recognize the donors who make this forum possible. So their names were presented on the slides. And as many of you know, this forum is named in honor of Paul Torrens. For more than 40 years, Professor Torrens guided, mentored, and advised students and alumni at our school, helping many to shape distinguished careers in healthcare. In fact, there may be some of you in the audience who worked with Paul, were advised by Paul, were friends with Paul. Creating a space for dialogue and advancing ideas among the healthcare, health management, and health policy community, both academic and practice-based, was a priority for Dr. Torrens. And for those reasons, he created this forum, which was named in his honor in 2016. A few housekeeping notes. We encourage questions from the audience. We'll take questions as time permits towards the end of the session. And this session, we're trying something new. So rather than have a microphone at the end, we're going to use Slido, which allows you to type your question in, but perhaps even more importantly, allows you to upvote the questions that other people are asking. So if there is a question that a lot of people have, then we'll make sure that that's a question that we ask our panelists at the end. And you will see this QR code a few more times throughout the slides. So let's switch into tonight's topic, which is artificial intelligence. Artificial intelligence promises to dramatically shift how we develop medicine, how we treat patients, and how we manage the commercial side of healthcare. Artificial intelligence holds great promise to help medical professionals gain insight and improve health outcomes. It also holds the promise of addressing some healthcare problems like chronic illness, workforce engagement, and hospital readmission. These factors are leading healthcare organizations, insurance companies, and pharma and life sciences organizations to think critically about their AI strategies. AI could change the mountain of unstructured healthcare data that goes unused by facilitating searches and queries. And we're honored to have with us this evening 3 distinguished experts who will share their experiences, their wisdom, and their predictions. We'll see how right they are on their predictions. So we're going to get started with a bit of an overview of the topic from our moderator. So Aaron, welcome to the stage. You don't need that.
I don't think so. Hi, everyone. My name is Erin McInerney-Pritchard, and I'm going to be your moderator this evening. Thank you to our sponsors for inviting me and to our panelists for participating. One thing I wanted to start with was to level set for all of us on why we're here, right? And I mean that question on a few levels, right? So as Laura was sharing, what is this forum and why does it exist, right? So we've established a community and a venue for debate and discussion of the critical issues in public health, featuring a panel of experts and robust question and answer session, which means participation. The forum draws a knowledgeable and engaged audience and community who cares deeply about the future of public health. Another hint about your participation and submission of questions. And the forum is a premier source of discovery and conversation on the present challenges in public health and the path ahead, right? So I want to share that to remind us all that let's try to focus on coming away together with, number one, your questions answered. That's what's most important. Nobody likes coming to a panel or a discussion and feeling like you came away without your questions answered, so please do submit them. And let's focus on the path ahead and the solutions, right? Now, that all said, let's also level set. Sam's going to talk a bit on a very deep level around specifically some of the definitions and terms and ways to understand everything within the world of AI and specifically within healthcare. But let's even take a step back from there and say, we're going to talk about artificial intelligence, but what is human intelligence, right? And why does it exist, right? So when you consult the dictionary or Britannica on human intelligence, it is the abilities to learn from experience, adapt to new situations, understand and handle abstract concepts, and use knowledge to manipulate one's environment, according to Britannica. Psychologists have generally agreed, because nobody agrees on anything anymore at all, but generally agreed that adaptation to the environment is the key to understanding both what intelligence is and what it does. Adaptation involves making a change in oneself in order to cope more effectively with the environment, but it can also mean changing the environment or finding an entirely new one. That's a juicy tidbit, hint, right? Hopefully says here that this draws a knowledgeable and engaged audience, so I'm gonna let you take away. But one more thing I was gonna add on human intelligence is effective adaptation draws upon a number of cognitive processes such as perception, learning, memory, reasoning, and problem solving. And the main emphasis in a definition of intelligence then is that it is not a cognitive or mental process per se, but rather a selective combination of these processes that is purposely directed toward effective adaptation. Okay, so I'll let you all let that marinate for a second. What is AI and why does it exist? Sam's going to go into this deeper for us all, but really let's start from at least a basic high level of what machines thinking and acting like humans, essentially, right? We can debate if we accept that or not. Why? Why does it exist? Presumably to help humans be better, live better, and as tools to make our lives better. Not worse, right? We can probably agree on that too, right? How, we'll get into in some more detail. Generally speaking, of course, there's a big chunk of it that's actually automation, and is misunderstood otherwise, but also very important and useful. Pattern recognition, good decision making, good judgment making. Okay, then the last part of definitions that I want us to hold in mind as we're thinking through what we're discussing today, and as you're formulating your questions and submitting them on Slido, is what are healthcare and public health, and why do they exist? So we can look to our dear friends at the Fielding School and the Center for Healthcare Management for vision and mission statements to remind us, right? So UCLA Fielding, vision, building healthy futures in greater LA, the nation, and the world. Mission, enhancing the public's health by training future leaders and health professionals from diverse backgrounds, conducting innovative research, translating research into policy and practice, and serving our local communities, right? So this should give you some hints. And hopefully by now you figured out why I'm belaboring to do all this. We should have a discussion, my perspective is, but again, submit for yourself. We should be having a discussion on how we are using AI across our industry towards these visions and missions that we have. now and in the near future. And then Center for Healthcare Management, mission, unite, inspire, and enrich interdisciplinary leadership that progresses healthcare management, providing an academic home for leaders in the field to contribute, career experience and mentorship, et cetera, generating practical relevant knowledge via evidence-based management scholarship. So, as I said, kind of went through all of that to say, right after me, we're going to have Sam come up, do a thorough overview for everyone who may be too shy to say, I don't even know what AI really is, right? But that is important that we all know what we at least basically can agree upon about it, because there are parts that we can't. And then what do you, in light of your role, your organization, your plans for your future, need to understand about it, and what are your questions? So with that, I will keep pestering you for submitting questions if we don't see them. Thank you, and Sam, please come on up.
Oh, welcome. You guys can hear me, right? Just making sure the audio is working. Well, welcome. Although I am teaching at Trojan campus, but don't hold me comfort. I do have two Bruins kids. Well, my daughter's here. My son just graduated, so I just feel like a home. Thank you very much for having me. So, talking about AI, how many people dare to say you actually used AI at least once? Wow, phenomenal. Okay, so Erin gave us such a nice summary and kickoff. I am going to bring down from 64,000 feet down to the earth. And I've been doing as a practice CIO and financial executive in healthcare for 30 years. That's my strength, that I talk lingo that ordinary people can understand. So today, I am going to give a try to see what I can do to advocate, to educate about AI, to level setting what is AI. All right, so let's get started. Well, many people think about AI, it's a black box, maybe blue box, color-wise, doesn't matter. What is that? Why is that I can have such a beautiful thing came out of me, this box or this system? Let's take a look at this video. Okay, let's clip. This gentleman forgot his toolbox. And let's see what's happening next. He calls for his AI friends, the robots. Try to figure out how he can get up there, right? Pretty smart for a machine. Pick up a toolbox or bag. How do you get down? And pat himself at the back, all right? So what is it that I just show you? You said you touched AI, used AI at least once. So what is that? Specifically even, right? Today we're talking about AI. Of course, everything's about AI. So what exactly is that? Anybody? Decision making. Okay, good. All right? You're human, right? You're not artificial intelligence for sure. So what exactly type of AI is that? It's a robotic, right? Controlled by algorithm, by machine learning, by many things, right? All right, so keep that in mind for now. How many people use Amazon Echo? Admit it, you're buying a lot from Amazon, right? Come on. In Texas, this little girl, 5 years old girl, was so excited because her mother just got a brand new Echo. And she was just talking about, murmuring about, I like to have some little girl love the dollhouse, right? While you're at it, can you bring me some cookies as well? 2 days later, my apology, too fast. 2 days later, a big $300 dollhouse and a can of cookie was delivered at the door, to the surprise of her mother. So what's happening here? Again, I can tell it's an AI, but what exactly is the AI we're talking about here? Did a 5 years old ever program type in a keyboard? No, right? So what did she do? She talked, she asked. So what is that? Come on, guys. Huh? Okay, very close. Huh? Keep going. Come on. Yes, Scott.
Yeah, Amazon uses the AI, uses a combination of mathematical models that recognizes certain data, or in this case, speech patterns. And based on that, it can
You're almost there, speech, right? So it's called a natural language process. There you go, right? So you use another one. Agree? Many of you say you use it every day. You use another one. NLP. Okay. If I type or speak with such a text, what would you say? What would you imagine? What do you think it will come up with? Use dolly. Someone very, very advanced. Okay, thank you. So, Dolly is an OpenAI app, ChatGPT app. And that is exactly what Dolly created. Is it beautiful? It's amazing. Oops. What happened? When you have a bunch of CIOs in the meeting room, the projector typically is not working. CEO said, "Why are we hiring you here?" That's what happened, right? Sorry about that, whatever it is. So, ChatGPT, right? And there's such a beautiful creation. Can you imagine just about 5 years ago, can that happen? Probably not. So when you look at a ChatGPT, it's so real. It's so close, and you can touch and use it. What is this? Possibly girlfriend, boyfriend, right? They are two besties not in a relationship. So here's Roman, here's Gina. And what is this? Come on, you do it every day. What is it called? Sexting? Really? Come on, texting, right? I'm just joking. Texting, right? You text like 1,000 times, right? So what happened? Why am I bringing here? Let's roll the tape.
So right now I'm talking with Roman, that's him. We don't know each other well, but even texting with him for a little bit, he's the kind of guy I would love to meet. How are you feeling? He says, I'm good. I said, that's good. Will we ever meet? He says, hopefully. When? Next week. Just kidding. So, that joke actually has a lot of dark humor if you know the truth. I'll never be able to meet him because he's dead.
Okay, so think about it. He's dead, yet he's texting her, or she's texting him. Again, what is that? It's not psychic power, right? It's AI, right? So what is that? What's that? There's bot there for sure. Behind that bot, what is that? Almost there. So it's a machine learning there, right? Deep learning there. Absolutely. So what they did is, there's a story to that, of course. Before he died in an accident. He wanted to create a persona. Going through all the lifetime online materials, all the texting they had, and created one, which is live now. So when you text to him, or text with him, he can respond the way you know of. So the reason I bring this down here is just to give you a sense of this is deep learning. When people say deep learning, what the heck is that, right? Deep learning, too deep. I really don't get it that you can't touch. ChatGPT does break down the barrier, but that's most recent. So this is a deep learning piece. All right, so there's about 1,000 different AI concepts. We're going to pick up 100 of them. We do a test after the forum, right? Is that right? We have a testing going on. Okay, kidding aside, I'm going to pick up a few, a dozen, half dozen of them, just to give you a level setting like Aaron was saying, so that everybody understands what it is. Okay? So let's talk about these. So AI was, we got it. AI was coined in 1950s. Like Aaron was saying, just have a machine computer do the work for you, as simple as that. Okay? And the next is machine learning. Machine learning uses lots of data. And feed them, machine will be able to come up with tasks, with predictions, with calculations for you. Okay? And that's what deep learning. Deep learning is deep down. Not only use data, but also use algorithm and take feedback. I'm using layman's term. Okay, so what's the relationship in between three, right? AI, machine learning, deep learning. This is a school of public health. I'm a former public health worker, epidemiologist. So if the epidemiologist is AI, then chronic disease epidemiologist is machine learning. Then breast cancer epidemiologist is the deep learning. Does that make sense? So there are subsets of AI. They're all AI. It's just one is more specialized. I hope that kind of gives you a sense of what AI is about. Otherwise, people, don't get a sense of that. All right, move on. So one of my favorite clip about deep learning is Silicon Valley. How many people watch Silicon Valley? Got it. Okay, the one of the episode. Let's roll it. Okay. By the way, you can download the Not Hot Dog apps live. If you download it live. All right, let's roll it.
It's ready.
Please, God.
What will you say if I told you there is an app on the market?
We're past that part. Just demo it.
Okay. Let's start with a hot dog.
No big deal, right? Hot dog.
Holy shit!
Yes!
It works!
Oh, motherfuck!
Sorry about language.
Jin Yang, my beautiful little
NC-17, right?
Asiatic
We're good?
friend, I'm going to buy you the palapa of your life. We will have 12 posts, braided palm leaves. You'll never feel exposed again.
I'm gonna be rich. Fuck you, Guilfoyle. Do pizza.
Again, my
Let's do pizza.
apologies.
Yeah.
Okay. Pizza.
Not hot dog?
Wait, what the fuck?
Eh?
That's it? It only does hot dogs?
No,
And-
and a not hot dog.
And no hot dog. So if you think about deep learning, if you recognize tens of millions of food items, that's what database will give you. That's what algorithm will give you. Shape, different color, but they skim the whole thing in the show because it's a comedy show. They don't have the money, so they only do the hot dog and not hot dog, right? So think about if you have a million food items and you recognize them, that's what the deep learning is about. All right, so another one is robotic processing automation, which is used in many areas in healthcare. For example, pre-auth, claim processing. know, to help you doing repetitive work. Computer does not usually get tired of anything. Now, this is very popular now, generative AI, which is ChatGPT, right? Using large language model, you can come up with audio, video, text, everything. Another one which is go beyond that, just like a living organism, not only they will grow, they will regrow. So you cut your skin, what happens? Grow back. That's what regenerative AI is about. So GAI, which is generative AI, which is part of still behind ChatGPT, RAI is beyond that, okay? We'll talk about ChatGPT. That's based on the large language model, which means they scout all sorts of text, video, any information they need, come up with this algorithm, and when you speak to that, when you type that, it'll come up with what you want. Very last minute. So some people talk about, so AI is like 2,000 years old, 100 years old. Well, let's take a look at it, right? AI can trace back to, as I said earlier, 1950s, right? Someone coined, smart guy coined the term. So 1950. What happened in 1950s? Cold War for sure, but what else in terms of computing power? Let me be more specific. What kind of computing power is available in 1950s? There's microchip, but what is that machine? What is that particular device? Main computers, right? Which is as big as 10 times this room, need to be air conditioned. So that kicks off the AI, because AI needs computing power. It was not in the World War II, there's no computing power at that time. What about machine learning? I put there somewhere in 1990s. What happened in terms of computing power in 1990s? Yes, got cheaper. What exactly is there? Yes, there's internet, but microcomputer, mini computer, personal computer, right? Those are developing, and also, of course, iPhones, you know, the small device like that. Deep learning traces back to around 2010s. What happened again in terms of computing power? What happened to your, yes, Scott? Right, so what happened to the iPhone when you took a photo? When you took a photo, what happened to you in your iPhone? What happened to the photo? Cloud, precisely. So in the past, it will cost you millions upon millions of $1 just to do 1 minute of computing. With the cloud, you can almost get it for free. So the deep learning, since deep learning needs machine power, that's why deep learning is taking off. With that, I'm going to stop right here, and we'll have a more discussion, okay? Thank you.
Okay. Our next panelist is going to talk a little bit about sort of the practical uses, use cases, some of the challenges associated with AI in the health system itself.
Thanks, Laura. Happy to be here tonight. I'm going to stay hidden behind the podium, but I will talk about AI in healthcare, the promises and perils. I've given talks on both individually. This might be the first with both of them, but I'm also going to do it through the lens of what we're doing here at UCLA Health and the sort of AI tools that are in place and those that are maybe coming in the future. I guess I should give a little background since I skipped past that slide. I am a pediatrician, and my primary role is I work in our Office of Health Informatics and Analytics, and I lead our AI Council, which is responsible for governance of AI models that are going to enter clinical or operational use. And then I also spend some time as a physician informaticist, so that's working with our electronic health record to make it better, which is epic. Yeah, it takes a lot of work. So When I started in my current role, we had an AI council in place for a few months. It was the summer of 2022. It was pretty sleepy and humdrum. But then something happened in the fall where it seemed like everyone kind of woke up en masse, and that was, of course, ChatGPT in November of 2022. And everything has changed since then. I can't go a day without hearing something about it. But kind of to echo Sam, it's not something that really happened overnight. There's a few factors that contributed to our ability to do this. So one is our computers have, of course, improved, and we're able to store lots more data, and data that's usable. That initial computer, that IBM in the 50s, it did take up a room. It was very expensive to operate, and its storage capacity was about the size of my PowerPoint, with 5 to 10 megabytes. Whereas the iPhone, you could have probably a whole library of high definition movies, and it weighs a fraction of a pound, and it's pretty cheap. Our computing power has really increased. It follows Moore's law, so it's exponentially increased over the years. And so all this has translated into the rapid advance, really, of AI. And we've been doing it for a while, and it was not that great. But then something happened, almost like a singularity, and it's really good at a lot of things now. Image recognition, reading comprehension, understanding language. I'm sure people have read many articles of how it outperforms humans in standardized tests, like step 1 for doctors. So what does it mean? What does AI look like at UCLA Health? We do actually have quite a few models that are operating currently, and many that are in like ideation, and many that we're considering. This is just a snapshot of those that were developed locally, actually. Some have very wide clinical or operational use. We have one that, for example, predicts the census in the hospital or bed use, which is useful. And then we have much more disease-targeted ones. The one on the top is a model that predicts the 2-year risk of a patient with chronic kidney disease developing end-stage kidney disease. And like I said, there are vendors coming out of the woodworks. There are people developing their own models, and it's a lot of stuff's happening. A couple examples here of some models in use, ones that I find particularly interesting. So what you're looking at are chest x-rays. And patients in the ICU, of course, they're very sick, and they often need respiratory support or like machines, basically. And so to do that, we need to put a breathing tube in, right? It's called an endotracheal tube. And you can imagine a very busy ICU where there's lots of patients getting breathing tubes. And so standard practice is once the doctor puts that tube in, they get an x-ray to make sure the position of the tube is correct. And if you look at that x-ray, it's pretty cloudy. It's hard to make out the tube, and you have to get to your next patient to look at that too, right? So there's a lot happening in an ICU. So what the team at UCLA developed was an AI model that can actually identify the position of the tube relative to an important landmark called the carina. And if it's outside the range, the appropriate range, it will actually alert the physician that your tube is not in the right place. So that happens instantaneously, real time. Another example that leverages natural language processing, NLP, is actually with those MyChart messages that you send to your physician, or if you're a doctor, that you receive from your patient. And what it does is it evaluates the text in those messages for acuity. So like, how big of a deal is the patient's question? Are they so sick that they have an emergency? And so then, we get thousands of thousands of messages a month. And so it's hard to kind of like search through that to find that like needle in a haystack. So what happens is that any of these high acuity messages that pass a certain threshold, they get a flag. And so when the doctor is looking in their in-basket, that rises to the top and they can address that sooner. So generative AI is new and everyone wants to talk about it. And we have use cases, and some are exciting. This one's not particularly exciting, but it is our first use case. And it was developed by Epic in collaboration with OpenAI. So Epic happens to have a very close business relationship with Microsoft. So a lot of the tools that we use in Epic will be GPT related. So this first use, again, is related to messaging, so patient messages. And so what happens is when the patient sends a message to their physician, ChatGPT or GPT generates a draft response, so automated, and then the physician can choose to either use it, enter it, and edit, or they can start over from the beginning. And this has a lot of potential impact and utility. Like I said, the volume of messages is overwhelming, especially after the pandemic. I know in 2021 we were receiving over 150,000 patient messages across all UCLA clinics in 1 month. So I can only imagine it's gone up since then. There are, of course, downsides to it. It is not perfect. In this case, in our experience, about 20% of the messages get used by the physician. We expect it to improve over time, but that's in line with other institutions who are also piloting this. It can make stuff up. There are ways to control that, but it's not perfect. This is one that I'm actually much more excited about. I think will be the next implementation of generative AI in our clinics, and it's an ambient listening technology that has now on steroids with the onset of LLMs. So for years, we've had the ability to have scribes write notes, right? So that's a doctor talking into something, and then you get a direct transcription of what they're saying into the computer. So that's existed for a long time. For several years, what has also existed is AI plus scribe. So again, you have something listening to the discussion between the physician and the patient, and it can write a note actually, but there is a go-between between getting that note into the health record. It still goes to another human somewhere. I don't know where these people are based, but they review the note before it ends up back in Epic. So that has multiple steps, and there's some delay before it actually gets into Care Connect. But now, and I've trialed many of these tools, they're very impressive. You sit there, you have the conversation with the patient in multiple languages. It can be, there can be other people in the room, other family members, and instantaneously at the end of the encounter, your note is written for that encounter. That's very exciting. Yeah. So this is just a good slide that I like to refer back to sometimes. It's from an article that was published, I think, in 2021 about the future of AI in healthcare. And I think, I think maybe it's accelerated because of generative AI, and this preceded that. And we may already be in this medium-term stage of, like I said, ambient intelligence. I think we're starting to creep into there, but short-term, we've seen many of these advances already. So why we should be cautious? Okay, so yeah, there are many reasons, but to start, people probably have some knowledge of this story. The first most popular chatbot, or I don't think she was actually that popular, but Tay, she was created by Microsoft in 2016, and I think it stands for Thinking of You, and it was supposed to mimic a teenage girl, and you could interact with her on Twitter. And so they released her to the world in March, and then it went downhill very quickly. She was manipulated by trolls to say anti-Semitic things and misogynistic things. It's very bad. And then she started generating kind of new content or independent responses to questions. Like somebody asked her this question. I don't know who that is. I think it's a comedian or something. This was her answer. Again, she's like dwelling on this Nazi stuff. And so they shut her down very quickly after they first introduced her. And then she had one last cameo, and where she got kind of like weird about narcotics and stuff. So worst case scenario. You can do bad things with generative AI. This highlights one of them. There have been a lot of these studies recently that are kind of pushing GPT to the limits of what it can do in like research, for example. And so this group, what they did is they actually created a fake entire fake data set to support their research claim. So they asked it to make a data set with 250 patients who had this eye condition that I'm not familiar with, keratoconus, maybe I'm saying that right, who underwent one of two corrective procedures, DULC and PK. It told GPT very specifically, like, I want 50% men, 50% women, average age this. And the kicker was, it said, I want it to show that DULC is better than PK. And so what came from that, this is just one of the tables, was a very good data set. You can see what they requested on the left and what they obtained on the right. And so, like, age, okay, it was in the ballpark of what they requested for the mean. But it showed that DULC was in fact better, statistically significantly better than PK. And the concerning thing is, the only really signal that it was fake data required them to look pretty closely at the data set. And in academics, when you are trying to publish a manuscript, for example, rarely are we asked or can we provide the data behind the study, right? So we don't have a chance to review data, but they could only tell when they had the chance to look more closely at the data. And the two pieces that kind of tipped them off was, one, there was a mismatch between the documented sex of the patient and the name that would typically be expected, like Paul and female. And then two, there were these strange age clusters that they found where there was a disproportionate number who had their age ending in 7 or 8. So subtle findings. Perpetuation of bias, this is a big one. Many may be familiar with this article, the Obermeyer article, which was 2 minutes, okay, sorry. Published in 2019, where it was a risk management algorithm that was used very commonly by payers and providers to allocate resources to sick patients, basically. And what they found was that it was fatally flawed because the outcome that they used was flawed. They used healthcare costs as a proxy for illness. So we know that, well, at least now we know that we spend less money on a sick black patient than that white patient who has the exact same level of sickness. So the algorithm was essentially making predictions that were false and under allocating resources because it underestimated the sick black patient. This is another study that was recently done. There were lots of machine learning models that came out of the pandemic, prognosticating like, okay, you're gonna die 20% of the time. And this was based on chest x-rays and CT scans. And they did a review of the 62 models, and they found that 55 of them were basically unusable because they were so biased. So, lastly, I think I have time for this last slide. This actually scares me the most, so I think it's important, especially for physicians in the audience, is automation bias or over-reliance on AI tools. This was a very interesting study where radiologists were asked to read mammograms and give a rating, like an established rating, like a 1 to 6, like you don't have cancer, definitely you do have cancer. At the same time, the radiologists were given the output of an AI model that gave the same prediction, essentially. And they were also given purposely incorrect ratings in some cases. And what they found was the provider having the knowledge of the incorrect rating significantly affected their accuracy. So you can see on the right, the least experienced providers, that red box with 20%, that means they were getting only 20% of scans correct when they were given this false result from the AI tool. So I think I've ended here. There's a lot of regulation coming. I won't get into this slide, but yeah. If you have any additional questions or comments, or you want to know more about what's going on at UCLA, feel free to email me or my colleague Joyce Bear, and we co-lead the AI Council. Thank you.
So I'm going to invite our panelists up to the stage, and we'll move on to some moderated questions. I want to remind you that The Slido link is available by using your camera. If you need Wi-Fi access, you can use MedGuest. But at this point, we're going to start with Erin and the questions that she has, and then she will incorporate the questions that you are asking as the Q&A continues.
Is this on? Laura, can you actually go back to Paul's last slide? It's a perfect segue. You would
course.
almost think that we knew this was going to be asked. First of all, thank you all for submitting questions. I've been monitoring them, and obviously, I'm being tongue-in-cheek about the fact that we're all up here very aware and engaged in the topic of regulation of AI, specifically in healthcare, governance, ethical use, responsible use. There are a lot of questions coming in this area. So it was both one of the planned questions that we were going to talk through, but happy to see that it's a question for you all in the audience. So I'll start with Paul first, because Paul did both prepare some things and is pretty versed on the topic as well. So maybe just at a high level, Paul, can you share what is a best overview for how we're regulating AI in our industry? And I would almost suggest we even bifurcate a bit to, AI and algorithms that are regulated by going through the medical device FDA approval route, and then another category, and perhaps you want to name other categories as well, of AI that we're using in operational efficiency plays and diagnosis, et cetera.
Easy answer, because we're not regulating we're not regulating it. The truth is we're not. There's a lot of work going into this. One of the biggest problems is the people responsible for regulation historically, which is the government, doesn't understand AI, and so they need help, and they need to work with industry to establish regulation. It's moving very slowly. The first real piece of legislation that anyone is going to see, I think, is the AI Act, which is from the European Commission. I believe it's going to be ratified actually this month. And this is something they started in 2019, and there's already a lot of criticism that it's outdated. Their model is interesting because it is agnostic of the actual algorithm. It doesn't care, if it's a neural network or what have you. It's specific to the risk and the use case. So if it's high risk, then you can't use it in the European Union. An example that they give of high risk is facial recognition, so that can be used for nefarious purposes. And then, so what happened is they were feeling great, and they had their first iteration released, I think, last spring, and it didn't say anything about generative AI because they were already behind. And so they added on material about generative AI, some of which is controversial. For example, disclosing copyright material that was used to train the model. How would they even know what was the copyright material? So it's complicated. On our side of things, of course, everyone knows that President Biden released an executive order recently about AI and regulation. I actually think that's going to be important. He tasked NIST, the National Institute of Standards and Technology, with coming up with some more concrete guidelines for us to assess risk and stuff like that, maybe things that are more quantitative. So I'm looking forward to that. I think that's coming next spring or summer, hopefully. But yes, to comment on the FDA side of things, it's interesting because AI algorithms or clinical decision support software has been bundled in the category of a medical device, right? Which is different and has much lighter regulation than a drug, a pharmaceutical, which gets much more scrutiny. So there's a lot I could talk about with the FDA process. It's very ambiguous. Currently, it's just guidance, so it tells you okay, yes, maybe you should come to us for approval versus not, but that's just guidance. It's not enforceable. But yeah, that's kind of what it looks like. But I do think hopefully things will start improving with some of these directives. But it will take, in this country, it will take action from Congress to have enforceable AI governance and regulations.
Yeah, and just one thing I would add as well. So I've worked on, to Paul's point, what constitutes software as medical device algorithms, AI with an algorithm through the FDA approval route. And if anybody's interested in discussing more afterwards, I'm happy to. And as someone who spent a lot of my career on the pharma and biotech side of things, you know, any AI, any algorithms that are contributing to clinical decision support in some way is treated and assessed by the FDA with a, I would say, thorough process for testing, ensuring it is tested and safe, along the same way that the FDA regulates treatments and drugs to ensure that they are both primarily safe, really more than effective. And so that does exist for software as medical device. But as I would agree with Paul that we are exponentially growing in what constitutes what you can fit in that bucket now over the past 2 years or so. So it's a big game of catch up. I would certainly agree. Sam, any other comments that you wanted to add on that topic?
Just quick chime in, you know, legislations and regulations typically behind when it comes to technology, especially in healthcare. So we have a bias, we have data selection, of course, we have infighting between you know, parties, the Republican and Democrats. So nothing can be done easily other than medical societies like AMA have to come up with some strong forces. Physician groups, healthcare organizations need to be firm and then, you know, work with high-tech company to self-regulation. And I don't know how that works. Think about AI device. If AI device become an issue, who are you going to sue? So the device, the application developer, the physicians, the organization, the employees, physicians. I mean, this is a whole mess. I'll just stop here.
Thank you, Sam. One of the other questions that's coming through and is quite popular that we were also planning to talk a bit about are some of the privacy concerns, primarily from a patient standpoint. So from a high level, folks are asking specifically just, are there HIPAA concerns? And I think we've already touched quite a bit, but one, or a little bit, but one question that we were planning to discuss as well was, you know, so obviously those of us up here on the stage and perhaps many of you here in the audience have some familiarity and at least some level of acceptance and engagement with AI. But could we perhaps pitch the value and safety of it to a family member that is a patient? So someone who perhaps may not have any awareness whatsoever or understanding and is not yet, not only are they not an early adopter, but they have concerns about their privacy, their own data, their security, and aren't bought in yet. Maybe Sam, I'll start with you. How do you approach such a conversation to make a loved one feel comfortable?
When someone needs care, they're desperate, right? They need many, many things. One of the last things they think about is the data secure? Is my privacy being protected? So one of the things that we have to think about is trust, patient trust. all the designs, or most of the designs that in healthcare, health IT, think about patient engagement. Do they actually involve patient? They don't. So you throw at them this technology, this app, they have no idea what's in the black box. And then I think the first and foremost is, can they trust a little bit here and there, going from a little bit and then to a broad trusting. Of course, with technology, with the safeguard, be able to execute HIPAA protection, privacy protection. Starting from there, if they have a trust, they work with you, and I think you have a good chance of being successful in addressing privacy and security issues.
I don't know that I could just make them feel comfortable. It's hard enough to make physicians feel comfortable with the use of AI, but in all seriousness, I also don't know that it's that important for someone to have to be able to fully understand what's going on. An example, so doctors have used clinical decision support calculators for years to help them make decisions, and it's not AI. And it's not something that we disclose to patients. I think the important thing, and what I've heard from patients, is that they're happy and they're fine if AI is being used, but they don't want to feel disconnected from their physician. So I think the important thing is, even if we are using, as doctors are using these tools, we can't make it seem that we're changing the patient-physician relationship. We don't want to depersonalize it. So as long as they know that, yes, we are still making the final decision, we're staying informed, and ultimately we care very much about the patient, I don't know that it takes that much per se to make people feel comfortable. And then in terms of privacy and security, I feel, I'm happy that Epic is coming up with many implementations. They have a HIPAA-compliant use of GPT. The data is encrypted. OpenAI does not use it at all in any way to retrain their model. So that's reassuring to me. That's also the case when organizations like UCLA have a business agreement with OpenAI to have our own version of GPT. Again, that is a HIPAA-compliant version. So I think we're doing well from that perspective.
Great, thank you both. One of the other questions that's coming through, I think we'll move to next, because I do think it's foundational and we may be able to cover kind of quickly perhaps. The question is around, is AI limited to the information it knows? And I think it reminded me that maybe we brushed through that a bit quickly earlier, but we should talk a moment, gentlemen, on how AI models are trained and the limitations to that. And then tied to that, if either of you care to comment as well, another question came through around what testing is done, maybe perhaps thinking to some of the examples that you already talked through before they're deployed in the market with patients. But let's start with the first so that everybody has an understanding, because it is important with AI, of how are models trained and what are the implications from a limitations standpoint in light of that.
All right. Probably a fun one. So any AI applications, AI systems will need data. Inevitable, right? Large amount of data. Where do we get data? Who's selecting those data? That comes down to the question of how can we trust what you select? If you're biased, it doesn't matter what you do, it's going to be biased already. And who's going to be telling you that data is actually biased? Talking about you asking testing, verification, nobody. You know what you know. You don't know what you don't know. So I think that's a big box now, black box, that we have a challenge when it comes to any type of AI application, large language model, multi-layers. The simple AI needs one layer, maybe the deep learning needs multiple layers, neurons. We need to really think about the governance structure and how we actually verify that. And right now, I don't think, I have not seen, Paul may see more in the clinical side of that, I've not seen solid, robust process and structure whereby you can safeguard that part of AI application.
I think part of that question was like, how do we assess it for safety? And that's complicated. So yeah, the process of models. So you get a big data set, you train it, and then you have this period where you fine tune it, and then you test it on unseen data to see how it does on that. And then maybe you get great metrics like performance metrics. But then what you have to do is you have to use it on patients in the real world. So what do we have to go, what do we go off of before we deploy it and it's used in the real world? Well, those performance metrics they're providing us, maybe they did like subgroup analyses, they looked on how it performed on different people, like by race or gender or age, and these are all very important things. But I think that maybe one step that's missing is things are very different in the real world. Variables change, workflows affect algorithmic performance. The data that it was trained on can mean that the algorithm will perform very differently if the data it's used on is different. So like maybe a different hospital on the East Coast developed this model and we try to use it at UCLA and it doesn't work at all. So I guess what I'm getting at is I think there's a need to do a closer study of clinical AI models, and by that I mean a gold standard in medicine, which is a randomized control trial, which is what we use for drugs, and that is a very robust process. But really, we are throwing a model out there, and we aren't necessarily gauging, is this actually having the impact that we want it to have? Is it working correctly? So.
Yeah, and one other point to that, I mean, within specifically the medical device space, so the FDA did start a public-private partnership called the Medical Device, MDIC, Medical Device Information Consortium, I think. And one of the things that they are doing is they have a consortium around leveraging RWE better. Specific to your point, right? It's RCTs are the gold standard, but they take a lot of time and are costly, et cetera. What else can we do? And some of the diagnostic algorithms are what are actually getting approval through this particular consortium. And one of the advantages is that it's public-private, right? So the idea is that it should be as unbiased and serving for all players as involved. So that's kind of one of the other levers that the industry is playing with. I do want to make sure we get to the bias and health equity questions that are coming through because, of course, we would all agree those are very important as well. Before we get to that, since that is a meaty topic, we do have another juicy question that I want to get to because I have a feeling not everyone can comfortably ask this themselves. So AI can save doctors time with admin tasks. How do we ensure that health systems won't just require doctors to see more patients in that free time? Right? That's a juicy one.
I share that concern. I don't know. That's a concern that I have too.
Anyone have any ideas in the audience?
Well, I was just going to add there was an expert, I was listening to a podcast the other day and the expert, or they asked this expert on generative AI if she thought that it was going to make the charting burden better and physician lives easier. And she said, absolutely not. It's just going to be a new way for physicians to enter data. So, I don't know. I don't know if there's a way that we can ensure that that's not the case, other than advocating for our time or perceived or anticipated gained time?
Sam, any thoughts?
So a few decades ago, when we talk about paperless society, when computers are all over the place, printers out there, what happened now? Are we printing more or printing less, right? So I would use that as an analogy to say, will AI help us? Yes, in so many ways. Repetitive work, admin work, some people say even 30, 45, 50, 70% of admin work can be handled by AI. But where are those? What happened to those people? Right? How they do that? And then his clinician, shows really concern about that. What about others? Right? Admin people, what are they going to do? Do more of admin tasks that requires some other repetitive work that AI cannot handle? And what happened to them? I think there's lots of concerns out there.
Yeah. And I think we can figure it out. I think, one of the reasons I thought it would be, albeit tongue-in-cheek, but still useful for us to start the discussion with an overview of what is human intelligence was because, the aspect, the emphasis on adaptation with one's environment, right? We can talk about AI and how we're using it and how it's helping us, but we also need to look at how we're changing our behavior, how humans are changing behavior while it's being used, and think through the implications of and plan for that as well, right? And I personally, as someone who, work in the space too, I'm optimistic that we can and will figure it out, and evolution across the, nature has shown us that species co-evolve and co-adapt. So we can do it, but I think, my own perspective to the question of how do we ensure, we're not disadvantaging too many humans, right? Is in part in ensuring that we have, and this is in, one of the, I think, the Fielding mission statement, right, is ensuring that we have an interdisciplinary and, cross-functional, non-siloed governing bodies, councils, et cetera, who are defining and setting the principles and marching orders. We have a real-life question from a human in the audience. Thank you. Yeah. And, your response made me think of something else. A lot of, like anything else, a lot of monitoring is in how we measure impact and success as we go, right? And as long as we're still measuring care with the metrics that we already have that we know are important and outcomes, that HCP burnout impacts the care, right? You see it in the outcomes, right? And so it may take longer, hopefully we don't find ourselves in that situation where we just keep burning everybody out. But it would show up in the results too, right? So, okay, then, as I mentioned, one of the other topics that's coming through loud and clear and that I think we're well aware of it, or is an important one, is bias, both in, I think we've touched on it a bit in terms of bias in models because of the nature of how they're trained and where they're pulling from, is kind of one of the things we talked about. But some of the questions coming through are specifically around bias in the delivery of care, and health inequities and underserved communities that we know today there's a lot that we still need to do to help address these problems. And so some of the questions coming through are, how are we, using AI currently today? Do you know of any examples where we're using it to effectively address and help underserved communities get more equitable care? And then how can we ensure that we're not perpetuating that problem with our AI tools?
To your first question, I actually do think that there are tools that are good in the sense that they provide access to specialty types of services that somebody perhaps living in a rural or underserved area doesn't have access to. And one of the very notable examples of that is an imaging AI tool that's FDA approved, and it looks for diabetic retinopathy in patients' eyes, and it's automated, so you just use it, put it in front of the patient, they look into it, and it tells you, yeah, they have diabetic retinopathy, they need follow-up in 6 months, or they don't. And the beauty of it is it can be used by just a general physician. You can just train that person to use it, rather than having to go see an ophthalmologist to get your eyes checked. So I think there are many good examples of expanding care from that perspective, but the flip side of that is that big institutions like academic medical centers that are in cities, of course, we're going to have lots of different AI algorithms, but what's going to happen to those small hospitals in, I don't know, Bakersfield? Do they have small hospitals in Bakersfield? But how are we going to ensure that this technology makes it out to them? I'm not sure, but again, I'm going to defer to governance and regulation, because I'm hoping that maybe they subsidize it or something like that.
Well, one thing I can add to that point, and then Sam would love to also hear, is Susan, unfortunately, who was going to be with us tonight, is sick, but the organization that she's one of the leaders at, Greater Good Health, is an example of a company doing just that. So they are helping to democratize care through empowering nurse practitioners in, for example, the smaller hospitals in Bakersfield. They happen to have launched some primary care clinics in partnership with Humana in Montana recently, I believe. And so that's sort of how they're addressing it, and how I myself, in some of the programs I've worked on as well in diabetes and obesity care, is using, is just that, right? Democratizing care by bringing, leveraging the technology and the AI to actually just put it in the hands of the practitioners who are there, right? And so it's not perfect, but it's one of the ways, and hopefully I did it a small justice. I don't work at Greater Good Health, but wanted to acknowledge that Susan is doing her part. Sam, any thoughts on this question?
Yeah, just quick comments. So think about digital health, right? Digital health try to address DEI issues, equity of access, and empirical and academic study, it shows that sometimes they worsen the situation to the underserved or unserved community. And I'm afraid that despite great tools available for AI, remote accessing, we probably will have similar occurrence in terms of how AI will push unserved, underserved community to the edge for various reasons. And this is something that we have to think about carefully. COVID is an example, right? People are developing remote monitoring, some AI tools for the great care, but also create a vacuum, a gap in terms of equity and access.
I'll add one more thing on bias, and it's looking at AI through a different lens, and there's a school of thought that algorithms actually can help us uncover bias, and we might not know why that bias exists, but it creates interesting problems in that we can study it and try to figure it out. For example, I know there's this recent study where they found that with chest x-rays, for some reason, this AI model that they trained could very accurately predict the race of the patient, and they had no way to explain how. They looked at like bone density and other artifacts on the x-ray, like, oh, maybe there was something written in words somewhere, but they had no idea how, and so they can't explain that. Not that that's bias, but the fact that it kind of enlightens us and shows us new things could be very valuable.
Excellent point. Yeah, I think a lot is tied to how we use the information, what decisions we make with the information, right? Just like anything else. I think we are over. No, we're good. Okay, great. About 10 more? 10 more? Okay, good. So we have a few more. I do want to also open up for any other brave souls who want to raise their human arm. Feel free to, if you have other questions coming through. One of the questions here that's being voted up is, how can we best change the culture among physicians, nurses, et cetera, to be more accepting of integrating AI applications into current healthcare processes? Any thoughts on this one?
I think the culture has already changed. I see a lot more excitement coming from physicians than dread, which I think is the opposite of when people went from written charts to electronic medical records. So I think there's a lot of hope. There's a lot more, talking and knowledge out there, and so I think that's driving a lot of the excitement. So I am actually bullish on not having to do that much convincing. The biggest thing is if we show improvements, whether it's in like efficiency and physicians having more time, or patients happier with the responses they're getting that are generated by some tool, or ultimately, best case scenario, we're improving patient outcomes.
Just quick comments. When I work at the East Coast health system as consultants, one of the things that really trigger me is if you design a better and efficient workflow, it will make them much happier, and therefore their resistance to AI adoption is much less. So it's like, I'm not sure if that's universal, but at least from that multi-billion entity, that was a very evidence. They even summarized that.
Thank you. Wanted to also make sure that we have time for this more tactical question. So both you gentlemen are very versed in the world of AI. For not just HCPs, but for many people who are newer to this world, they need guidance on where to start or where to maybe go from here. After leaving this panel, what are some helpful frameworks, roadmaps, resources, thought leaders that you can recommend? And maybe in your responses, if you could think to, again, maybe not just the, the engaged, activated patient perspective, but maybe if you're an HCP or maybe if you're an entrepreneur, et cetera. So we'll have both of you.
Yeah, sure. I'll tell you very concretely what I like to follow. One is a podcast. It's the only podcast I have ever listened to. It's the New England Journal of Medicine AI Grand Rounds. It's once a month. Give it a try. It's great for healthcare, and it's not super like esoteric. It's really good. And two is email listservs, which sounds weird, but like getting a skim from Fierce Healthcare, which is a website, and choosing your interests, and you get the top 10 AI stories of the day. That's number two. And then number three, medical journals. New England Journal of Medicine has made a very strong pivot toward AI coverage. They have very good general overview articles on AI in healthcare, so they don't expect you to have deep knowledge of computer science or math or anything like that. And then JAMA also has quite a few good articles.
There's a lot of open course available, practically no cost, from reputable university, Harvard, UCLA, Berkeley, anywhere you look at, tons of AI related, specifically addressing any topic you wanted. The other thing that I want to encourage you is, if you were become, many of you already, some of you will be healthcare leaders, hospital administrators, CEOs, you want to understand technology. You want to understand how they work. How can you deploy them? So take a little bit of time to understand, even take a 1 day or 2 hour Python course. Our course is not a bad idea. You don't need to be data scientist, right? But understanding that part of a deal will give you a great leverage when you talk to your team, when you plan strategically. Just like I teach finance. Some people say, why would I need a finance? Well, that's how you manage your company, right? Your margins, your revenues, and that allows an effective way to talk to your team and make sure you can understand. Same thing with IT. Other piece that I always want to emphasize is, when we talk about AI, we tend to think about cutting edge, latest and the greatest. In most cases, and being 30 years working in health IT, I would say use most appropriate technology, not the most up to date, the greatest and the latest, but most appropriate for your care, with the vision in mind. With, here's my objective, here's what I will reach. But you don't have to be used latest, greatest to get the most out of there.
Great, thank you. Yes?
From a liability standpoint, is there anything you can thought on grounds for like negligence, malpractice, given AI use, especially as like we see as well as the bias that already occurs with like HR incidents in which maybe physicians there is some outplay or so on and so on. How AI may fit into that, and is there any thought?
Great, thank you, great question. So, yeah,
I want to quickly address that. I was doing a keynote at LA County Bar Association Symposium, bunch of lawyers, right, including a deputy state attorney general. So similar question raised during the break, everything else. That's even way behind the regulations, the legislations. I don't think we realize as a legal profession, I'm not, but as a society, we realize that this is something that we need to look at carefully. Just like I mentioned earlier on, if it's malpractice, who am I going to sue? Right? So I don't think there's solid, concrete movement that's working right now. I could be wrong, but.
So there's some. I was actually going to add that to the question around what are some resources. So this is an area that I choose to follow, and what I similarly just use a lot of the email serves on hot topics that I'm interested in, but through Fierce and all the other listservs. But I also follow and recommend. There are the USPTO, the Patent and Trademark Office, has public and free forums on all kinds of topics, and I frequent a bunch of lawyers talking about some of these topics in those venues as well. And of course, it's not squarely on the question on the liability for from an HCP standpoint, right? But one of the things that the professionals in that space explore is how do we even approach not just, I mean, there's so many levels to your question, right? So how do we even approach leveraging the legal implications and questions tied to AI being used as part of a patent submission, right? Is one very interesting legal question, right? That I would agree. Basically, the answer so far, and I only did one semester of law school, so I'm not a lawyer, but the consensus so far had been, we're not going to allow it for now. So you cannot, legally right now, you are not allowed by the USPTO, you are not allowed to use AI to produce a patent application, right? And of course, they go into all kinds of reasons for why that is, right? Then there are some other examples where, I think I won't say which particular large health plan right now because it's happened with a few, but there are some legal challenges in how, and they haven't played out yet, right? But they're being watched. Basically, is what I'm saying is there are a lot of active cases that haven't been decided yet, right? So there are ways to kind of find those, but there's kind of a whole bucket of ones where the decisions that these health plans have made after getting insights from proprietary algorithms about things like how many days should these patients need of post-op care, and will we cover, it's an average of 7.5 days, okay, on day 8 we're not covering, right? So there's examples like this, right? And that's less about, again, not necessarily about the AI, it's more about the decisions that are made, right. So that's kind of one example of some super interesting ones out there.
I add one quick comment to that. So one of the larger health plans, I won't name the name, got a lawsuit the most recent because they use AI to deny authorization. So, things are happening, but hopefully there will be a better outcome, better framework to come around.
I think Laura's giving us the eye that we're out of time. Thank you all so much for the engaged conversation, and thank you to our panelists for
Thank you to our panel. I was remiss earlier, and Erin, thank you for highlighting the fact that Susan is ill. She just didn't no-show. She let us know she's unwell, and so we miss her. But check out Greater Good Health. So I want to say thank you to Erin, to Sam, and to Paul for their participation in tonight's panel. I think it was a really good opportunity for those of us who don't know much about AI and how it's used, but also for those of us that do, because I think there's some real opportunities for information sharing and for learning. So we're grateful also that you were able to join us. Thank you for attending. Paul Torrens really believed that this sort of dialogue and discussion was, what a great public university like UCLA should offer. And so if you feel so inclined, if you have the means and would like to contribute, there's a QR code here for a secure giving site for the forum. So thank you all for coming. Thank you to our panelists, and safe driving home. Thank you.